You went into army of British.
Yes, Taliban, and I am the British soldier. I shoot you, you shoot me. We are bound to bring both of us to the hospital. In cardiac MRI, it used to take me 45 minutes to an hour to report a cardiac MRI. Today, we have developed an AI program which does it in 30 seconds. So, thank you. Thanks, Dr. Vimal Raj, to be here. And so today, what we do at this podcast really is have a conversation around topics of healthcare, topics of leadership in healthcare. So that's one of the things that we cover. So it's very conversational. So basically, it's not an interview. So we will have a overall, in general, discussion about your journey, about your views on radiology, my views on radiology, and it will be like more a conversation around that. In general, there are some areas, of course, for sure, that I want the listeners, takeaway for the listeners in general. Those would be is radiology as a career, or, in terms of, so that people know what it takes to be, what's in general the future of radiology, definitely the hot topic of radiology and AI. So these are definite ones that I would want to cover in general, but otherwise it's going to be just a conversation between your journey, and I'm sure there's so much to learn from your journey. So let's start there. Begin in terms of what from your childhood, right? What drew you to medicine, or how did it happen? Was it an accident, or was it deliberate, or where did it start? So first, Amit, thank you very much for having me in this show. I'm really privileged to be here. Me becoming a doctor is a interesting story, I'd rather say, and lots of things attached to it. And I come from a background where my parents were in armed forces. So I'm a South Indian, but born and brought up in North India, and every 5 years we would move to different parts of the country.
Where all you would have said?
I was born in Pune.
Oh, really? Yeah. Oh, that's not what I knew. Oh, okay.
So, yeah, I was born in Command Hospital, Pune.
Oh, okay.
And then we moved to Chandigarh.
So your father was also a doctor?
No, he was not a doctor. He was in the Indian Air Force. He was a trainer in Indian Air Force. Then Jodhpur, Bangalore is where we spent all our life. And in 10th standard, I wanted to join the NDA, National Defense Academy, and wanted to get selected.
Right.
So I was always aimed to go into the armed forces. That was my destiny. I always wanted to do that. Somewhere down 10th standard, Dad told me that, Vimal, you should join armed forces, but you should join as a doctor. The armed forces needs more doctors. They need more medical professional. And that was one of the directions that I wanted to go. So NDA, I got selected, but I did not go because then it was the aim to become a doctor. And even then I was very, very technically oriented. I was very good at my maths and physics, more practical skills. And then when came 12th standard, the Indian family story in our generation was doctor, engineer. One person in home becomes a doctor, one person becomes an engineer. It was my sister who was meant to be the doctor, elder sister, and I was the engineer.
Oh, okay. So it was like decided.
It was decided. So intelligently, I keep teasing my sister. My sister got less marks, so she did not become a doctor. She became an engineer. Which basically led to the fact that it was on me now to become the doctor of the family. And fortunately, I did well in my 12th standard and I became a doctor. That was, so armed forces, sister going into engineering and me having to go into medicine is where we went into medicine. And did my medical education in Bellary. All along, even in that time, I clearly knew that I am a technical person. But it changes later on.
Yeah.
And that actually defined what I do where I am today is defined by this whole attraction towards engineering, attraction towards practical skills, getting your hands dirty in terms of technology, learning newer things. And medicine was, I wouldn't say hard, but was not that enjoyable to me. Because in medicine, you have to learn a lot of facts, which you have to memorize. And it was not practical learning. A lot of it was not practical learning. But with God's grace, I did well in medical school. I did reasonably well, where most of my colleagues, my friends, my seniors were surprised, saying, we never thought you will pass. But I actually was quite one of the toppers in the college. So did well. So I take a train to Delhi, and that's where my SSB is. I land in Delhi, and it's the day when 9/11 happened. The Twin Towers got destroyed.
You mean when you went for the AFF, for
When
the
I went
army
for the SSB interview, 9/11 happened. And now it's all, the reason I'm saying this is all connected.
Wow.
Okay. So I go in, and I have a very good interview. I have a whole selection process. They say, what do you want? Army, Air Force, Navy. I wanted to be in Air Force, so that was my first preference. They said, you have qualified, but we will not send a call letter for you because of the Twin Towers. There is going to be enhanced security check on every recruitment that the armed forces does.
Even in India?
Even in India. Because the entire world got shook by the security lapse which had happened. So usually they have a 30-day period. So they said it can take anywhere from 60 to 80 days for us to send you a call letter.
Okay. So they will do your personal background check.
Exactly.
More detailed
Before they will take anybody.
Wow. Okay.
So at the same time, I have always been fascinated with education and training that happens in Western world. And the Indian system of giving entrance exams, which is highly competitive, where you have to mug up a lot of things and vomit out, was something I was never good at.
Though you kind of...
I did, but MBBS was a different level. The post-graduation courses and exams are very, very different.
But before the post-graduation, you went to the armed forces, or
Yes.
after that?
So after MBBS,
You went.
armed forces, I applied for it. And at the same time, I had applied for an exams to qualify and work in UK.
Oh.
Okay, so the date of interview to my flight, which was booked to go to UK, was 3 months. Okay, and it was whichever comes
But how did
first.
UK happen? Like what made you look at UK? Was it so natural at that time to... Not really, right? I mean,
There was a big outflow of people going to UK and US at that time.
Okay.
UK and US both were happening
medicine.
at that time. In medicine, a lot of people after MBBS were moving out, especially those who felt that what they wanted to do as a career was not very well established in India. Or the ones who felt like me that they are not suited to give Indian entrance exams. Okay, and I had done basic exams. There were some basic exams which you could take in India, which I had cleared. So I had to go for one specific exam in UK. So from the date of my armed forces interview, there was a 3-month period for the UK flight. So I said, whichever comes first. Call letter comes first, this comes first, whichever I'll do. The call letter didn't come.
For 3 months.
For 3 months. It just did not come. So if 9/11 hadn't happened, we wouldn't be sitting here and chatting with each other, because my career would have had a totally different trajectory. So the time came, I took the flight, I land in UK, and I call my parents and say, I have reached. Dad says, your call letter has come. It was just by 24 hours, maybe 12 hours, 24 hours.
Seriously?
Yeah.
Wow. So you missed the armed forces, to do the armed forces in India by 12, 24 hours.
Yeah.
because you've already gone there, you thought you will continue that.
Absolutely. Yeah.
And you did that, but ultimately you went into army of British.
Yes.
So you went to British Army. So you have to tell, of course, how that happened. So
Yeah. So as they say in Hindi, the kida. I always had that kida of wanting to be in the armed forces. I love the disciplined nature. I love the hierarchical system in armed forces. That was there. So this was all in late 1999, 2000.
And I'm guessing that that's primarily because you saw that growing up.
Growing up. Absolutely. Absolutely in that. So I went to UK, did my exams, did well. And all along in my career, I wanted to do neuroradiology.
Even earlier.
Even when I'm doing medical school, I knew I wanted to do neuroradiology.
How did that?
And interventional neuroradiology for that matter. And main driving force was the medical school that we were in India. It was a government medical school which lacked a lot of facilities, where I saw a lot of patients die because of brain issues, which an interventional neuroradiologist would have sorted out and saved a lot of lives. And that kind of was something I wanted to do.
That kind of made an impression to you when you were learning medicine. And this is like in MBBS, in Bellary.
In Bellary. And that is when I also realized the interventional neuroradiology in India at that time was at its infancy.
Yeah.
And people were doing it, but they were not very mature units. Only Nimans was one of the units which was doing a volume, and AIMS was doing, but it was not a very mature system. And that was the intention, to go to UK and do that. And one of the good things about the UK system was they did not allow people to join radiology straight after MBBS at that point in time.
Really?
They were just not allowed to.
Oh.
Because in Indian system, what happens is now you do medical school and then you join radiology. You have no exposure to treating patients. The clinical exposure is just not there.
And they want you to give that.
They want you to have that clinical exposure, because then you know whatever I report, what impact it has on patients' management.
That's very interesting. Oh, so that solves my puzzle of, because when I was going through your profile, the first time I actually came across a radiologist profile who has done surgery. And you did surgery and then went to radiology, and I was like, how did that happen in the first place, right?
So yeah, it was one, it was a requirement, and second, because I wanted to do intervention, I wanted those skills, the surgical skills of hand-to-eye coordination of
it was planned
surgery
in a way.
It was planned in that.
Wow, nice.
So surgery, and while I was doing surgery, I volunteered myself into British Army. And
your army that didn't go.
No, it never went away. It never went away. So I volunteered and joined British Army. British Army they have an interesting concept called as territorial army, whereby if they need 100 people in their armed forces, they only...
This was after doing surgery, or?
This was during surgery. This was
You're not a radiologist yet.
I'm not yet a radiologist. Okay. So if British Army needs 100 armed personnel in the army, they'll only have 20 people who are full-time. Remainder 80 are all what they call as territorial army, which is basically lawyers, doctors, policemen, plumbers, and all that. The infantry will be the 20% that they will recruit. Everybody else, HR and everyone, they will take from the public sector. They'll say, you keep working what you are doing, dedicate some time to us. So in a year, 2 months I would spend with the army, where I don't train as a surgeon or radiologist, I train as a soldier. So we would be doing shooting drills, we'll be
really?
And all that.
Also, even the standard army stuff you have to do.
Every standard army stuff, because
you know how to shoot and all.
Oh yeah, I'm a decent marksman in there, and I'm very good with my navigation skills. I had the privilege of getting trained in a military academy called as Sandhurst. This is the academy where all the royal family go. The British Royal, the Middle East Royal, all the big army officers go and train. So I was trained there.
You got to meet some of them?
Not in my time. No, there were no. I think Prince Harry and all, they had just left before me. They were ahead of me in their training in there. So that's when I volunteered, and they loved the fact that I was a surgeon. They wanted as a surgeon. And then when I took up radiology, at that point in time, around Gulf War, we had when I say we, the British Army had a CT scanner in a ship parked on the Gulf Bay. So all the patients and soldiers were being flown into the ship, and scans were happening there.
Tell us more about this. So how does this work? And you were a radiologist already?
Not at this time, but yeah, in another 4 years' time, I became a radiologist.
But you were still flown?
I was never flown. So I was not part of the Gulf War because at that point in time, I was still getting trained.
Okay.
So my seniors at that point in time were all doing remote reporting. We were doing teleradiology work. There was armed personnel, doctors, etc. on the ship who were treating patients. CT scan was there. Patients get flown in. We scan.
So the injured...
Yeah, injured soldiers.
Injured soul of British Army.
Okay, so that is the common conception, but it's not true. Anybody and everybody.
Even the enemies.
Even the enemies.
Wow, so there's some honor there.
There is a big honor there, and I'll tell you about this, which... so later on, when we fast forward, and I was in Afghanistan, where I deployed as a army major and deployed as a radiologist in there. We will have, so for example, you are, let's say, the Taliban, and I am the British soldier. I shoot you, you shoot me. We are bound to bring both of us to the hospital. As a doctor, we will treat both equally. Okay, and if you are more unwell, you will be treated more than me. It doesn't matter.
And that's the mandate from the British.
It's a mandate, and we are all doctors at the end of the day. And the worst bit, which is funny also, is when you're in the intensive care unit, you may be in the bed opposite me, and
you might have actually shoot each other.
Yeah, we may have shot each other, and you are sitting next to me.
Seriously, that happens?
That happens. And of course, we cuff each other. We cuff you to the bed, so we cuff this person also.
So what's the experience as a doctor and a radiologist for you there in terms of what would be some of the learnings as an individual that you got from such an experience? Because it's a very rare kind of an experience, right? I mean, what made you volunteer? In the sense, is it that same army thing that you wanted to be a part of?
It definitely is the army thing, but more than that, I feel this sense of commitment, sense of giving back to the community, giving back to the world of what I have learned, and doing things which is righteous in that manner. And the fact that in the war zone, we are going to help a lot of people, it was a big calling for me. And then at the end of...
You had any friends with you who came as well?
My unit, army unit came with me. So we had a lot, but then I made a lot of other friends there, in there. And interestingly, the radiologist there, so the trauma care is the best in the world you will get. Anywhere in the world.
Help us understand more. So how would that work?
The armed forces which manages is a combination of different country doctors. So we had Americans, we had Dutch people, we had British people, all put together. And everybody there is purely for patient care.
Yeah.
There is no politics.
Yeah.
Okay. There is no finances involved. And there is a very, very clear system of hierarchy.
Okay.
There is a very clear system of hierarchy. Don't care who you are. You're here to manage the patient, which doesn't happen in normal hospitals. There's always a politics there. There's always a hierarchy there. And, cardiac surgeons are
So in a way, you're saying that was easier to
It
manage.
was very easy. Everybody knew their role. Okay. And for example, if all our patients, the base was in the middle of desert. Okay. It was a huge base. About 10 miles in either direction was plain land, because people can come and attack us. So that was strategically put in there. In our base, we had around 40,000 soldiers. So it was a city on its own. And the patients, soldiers, civilians who get injured during this gunfight, all would come in helicopter. They won't come on road. Yeah, it's all our patients would come in helicopters, and we would bring them in. Some of them were in very, very, very bad shapes. And the hospital became a target for Taliban over a period of time, because Taliban would get into a gunfight and they would say, we've killed 20 soldiers. 3 days later, the forces will release a news that there was a gunfight. 2 soldiers died. Taliban says 20 and we say 2, because Taliban has blown so many people. We've actually saved us 18. So they were like, whatever we are doing, these guys are saving them. We might as well blow these guys out. So we've had rocket attacks and stuff in our hospitals. We had to go in bunkers and stuff. It's an experience.
Quite an experience. So if you have to borrow any learning from those times, and just imagine that you have all the power to execute in this world, in the civilian world or whatever, in the org, which today has, what would those be like? What would the couple of things that you think you would love to just execute if you had all the power to make it better? Because in a way you are saying that discipline actually and clarity of roles, if I can, what I get from you, and also the context of the situation of a singular focus of care helped all of you to deliver much better and felt more fulfilling as well. Is that right?
Absolutely.
I mean, if I summarize what you're saying, right? So if that is what you feel, what is it that if we had to create a similar thing here, what would those be, and what can a couple of things be done?
See, I think what worked very well for us was that we worked as a team with a single focus. And the single focus at the end of the day was to save that patient's life. Okay, and we were what shall I say? We lived together in such close proximity, and we knew that for the next 6 months, this is what we're going to be doing. Day in, day out, this is what we're going to be doing. And we knew each other so very well. Okay, if I say, look at it, the radiographer will know what I'm asking for. They will do that, even without me having to say. So the biggest learning for us was the teamwork. This to really be
It makes a difference.
It makes a big difference.
Give an example, like.
So we were part of a trauma team. Okay. Now, a soldier gets blown up from an IED, improvised explosive device, comes in. Okay. His legs are dangling. Okay. He has one leg left, the other leg is dangling. And we have a protocol. Okay. That 6 people will attend to him. And on the table, there are 6 people attending to him. We know who those 6 people are. No 7th person is allowed. And there are about 15 people standing there where the team leader calls them. I want you, I want you. Nobody is allowed to come. Okay. Now, in here, in normal practice, the person comes and the leg is dangling. The orthopedician will come running to tackle his leg. The cardiac surgeon is here. The anesthetist is there. The person who is a team leader may be the most junior person in the whole gang. And the person behind, there's a yellow line, actually, we say don't cross that line. And nobody can cross that line till that team leader has actually called.
And the team leader doesn't necessarily to be the most senior person?
It's usually not. It's an emergency physician. It's an emergency physician, and his boss may be beyond that yellow line, and his boss will not come until this guy comes. So, and I am there as part of the trauma team. This first 6 people, the radiologist is that first 6 people, which you don't see anywhere else in the world, because we are actually doing an echo, we are doing an ultrasound, and saying
Diagnosis.
this is fine, safe, and then I step out. No, there is blood, take to OT directly. So the orthopedician in that case is itching and saying that leg is falling, and this junior is saying stay there. He's not going to die because of his leg, he's going to die because of other things. First, let them get everything, and you have
But
to.
why is it so hard to say implement it in hospital setting in normal hospitals? Like
Ego. There's a lot of ego in healthcare, which doesn't work. And we don't work as a team in a closed environment. If you see what happened in Afghanistan, we were working in a closed environment as a team, which basically meant we know we are only dealing with seriously ill patients. We are only dealing with gunshot injuries, IEDs, and everybody knew their role. In normal healthcare, you have such a Pandora's box. You have no idea what's coming in next. And for everything, you can't do. So,
true, but can we, just for the sake of conversation, because this is very exciting, can we, for example, hypothetically, okay, can we create a zone within an hospital saying this is for emergency alone, which anyway is there, right? There is an emergency physician in an hospital as well. He is that team leader, he or she is that team leader. And we create a task force along with them, which only does that for 6 months in a year and follows exactly these protocols. And that care at least will get elevated a lot. Not everything, but that care will get elevated a lot, which itself is immensely useful, because that's the care when people need it like the most. It's the emergency kind of care. Would that?
see, this is what actually happens in a restricted environment. So if you go into, for example, if you come into our hospital, you will see that there is a operating theater, OT, team 1, team 2, team 3. If that team 1 is made up of a standard group of people for a standard period of time, the efficiency of that team is super high, because they know each other. They know what this person wants. They know how this person operates. What's the next thing they're going to do? And the same thing in a closed environment, in an emergency team, you have a trauma team 1, trauma team 2 or 3. And if that team constantly work, they very well know, I know this is what he's going to do. I know this is what she is going to do. And the efficiency improves significantly. The communication becomes so much more faster and easier to do. And I think the biggest thing which worked for all of us was that we were there for one singular purpose. And that was one important thing. Then we were there for one singular purpose. There was no finances involved. There was no promotion involved. The hierarchy did not matter to us. We were all given ranks. We had colonels, we had majors. We were all sitting together and eating lunch. We all are going in the same vehicle. There is nothing to aspire apart from saving that patient's life, which makes a big difference.
So in a way, this is so much relates back to what we were earlier discussing about the need for leadership in healthcare. And one of the roles of any big leader is to kind of galvanize the team towards a singular purpose, right? And so, I mean, somewhere probably more of that has to happen.
Absolutely.
And I understand in a condition like a war, that becomes easier and natural to happen because the purpose is so kind of compelling that it happens. But how can we create similar conditions in hospitals? So for example, today someone is listening this and is running an hospital or intends to run an hospital. What is it that he or she can take from this and put it into their system so that the chances of they delivering that kind of care and team, building that kind of a team, they're the leaders for that entity, they can take away from.
See, I think if you believe in setting up such a hospital which works in an efficiency that we see in these units, is the first thing is ethos of that leader has to be very, very clear. And that ethos has to be pushed down to the entire team. And the leader has to lead by examples. And there has to be very, very, very clear communication and saying, this is what is expected, this is how we are going to do. We've had teams within our departments and in every hospital that we've gone and worked. We see some teams work, some teams are very dysfunctional in there. And there are many reasons for that. To make things work, I think everybody has to understand their purpose. Everybody has to realize what is it that they are contributing into it. And it has to be led by an example. Strong ethos of how to do it. And the third thing which happens is communication. If your communication channels are very, very clear. We used to have this. So we will have a trauma case, and that trauma case will be 3 hours, 4 hours, everybody's time. And then we go sit together and say, what went well? What did we do well? Is there something we can do better? Did we not do this? And interestingly, as a team lead or as the radiologist, as a surgeon, you feel it was great. It was fantastic because we saved the patient's life and stuff. But then there are people in the team who will turn around and say, that was disaster, guys. I didn't know what you were doing. You may know what you were doing, but I had no clue what you were doing.
Right.
There was no communication. And in this case, the patient survived, but we don't know what will happen next
time.
So the communication becomes a very, very important.
And what would be, say, 2 to 3 things one should do to ensure there is a better communication amongst team members?
See, I think what happens is from the top down, the leadership of a hospital, as the hospital grows, the leadership of the hospital distances itself from the people who are actually delivering the services. And there is a expectation that middle level managers
Would do that.
Unfortunately, the middle level managers are often not as inspirational as the leaders are, and they are not able to pass
It's
on
very
that
much a
message.
corporate story as well.
Correct.
Yeah.
So what is important is that the imbibing the ethos of the institution into the entry level person itself is very, very important. And that happens through regular dialogues, regular meetups, and saying, hey, what's happening? What have you guys been up to? This is what you've been doing. Because in today's hospitals, we always hear, this is not well. We need to change this. This is not well. This is it. Nobody comes and tells, guys, you did very well last month. We got this compliment from these patients. These patients are happy about it. We seldom get positive feedback. We always get negative feedback. And over a period of time, it just becomes noise rather than a proper communication and a dialogue. So you have to speak with the entry level staff, and the top level management has to take time to be able to do that, because they have to inspire people. Okay, and that's what lacks. We never had the problem of inspiration in there.
Yeah.
Okay, and we were very much interested in that. The other thing which I feel, which is a very common problem that we face nowadays, is people get bogged down by the sheer volume of things that they do. And if I am doing 101 things, then my passion for a thing will go down.
You don't have the bandwidth, the energy to give that.
Correct.
But it deserves time. So knowing each other, right? So one is, of course, you know each other well if you work long enough. But are there ways to accelerate this team formation building? I mean, we always have this corporate trainings around team building and stuff like that, right? But are there specific things in army or in your experience otherwise, especially in the healthcare environment, that helps to build this team strongly?
So we've done this, and what we have realized is that the day outings and stuff like that are more than an icebreaker, nothing else.
Nothing else.
Okay, they are just an icebreaker for people to just know that.
Right.
What works in healthcare is often the night shift. If you're with somebody in the night shift, and I used to work in emergency departments and they were long shifts, and you would know the person's much, much better in a shift where you have nothing else to do but just doing your job. And you're working with them together, and you get to know them, and you talk to them, and you realize what their strengths are, what their weaknesses are. But everybody can't do night shifts. It takes time. It takes time. And there is no easy answer to it. We have found that if a person joins our unit, for us to know them, it takes anywhere from 3 to 6 months. And often there's so much of churn in the system. If they move out or they move around, then you just get to not know them at all. And we have been very particular about how we recruit people, because we traditionally in Indian healthcare radiology sector, recruitment is based on clinical acumen.
Yeah, that's generally one of the biggest.
So you basically give them examples, you ask them to write a test, etc. We don't do that.
Oh wow! So what do you do?
We don't do that, because when we are taking a trainee, we are taking them to train them. If they're already good at their job, then they don't need our training. So
you generally take freshers?
So we take freshers after med school, after radiology. We take intermediate people also, because we will train them. That is our job. What we actually do is we assess them as a personality. So we ask them situations, we understand what drives them.
What do you look at
them?
Right.
So we look at people who are committed to work, okay, and we like people who are happy to admit that they don't know something.
How do you find they're committed to work?
So one of the things which we very openly turn around and say, hey guys, we work 12 hours a day, okay, and we expect you to work 12 hours a day. Are you okay with that? Often in an interview, they'll turn around and say, yes, we are okay, because they want a job. Yeah. That's how it becomes. And then when we dig deeper and say, you're stressed, this is the situation, what do you do in that situation? People come up with answers. People come up with answers where you clearly pick up and say, this person is not cut out for doing this, or has not had that experience. I have trained around around 80, 85 fellows over a period of last 10 years. I've gone wrong in about 6 of them.
Oh, you do track and measure how?
Well,
right.
During our course, we realize.
Oh, you realize?
We realize that we've had 6
That's
people
an amazing rate.
who've quit and gone and said, sir, we can't cope with this work.
Wow,
We can't
that's a good.
Yeah.
Because recruitment is a big challenge, right?
Absolutely.
I mean, we don't. It's tough to know from an interview. At least I find it very tough to know from an interview everything about what is required or what you are looking at, to really find that with evidence, to understand and say, oh yes. Sometimes it's obvious.
Yes.
And then you are really happy to but many times it's not.
Yeah.
There's
no foolproof way. So as I said, we've also gone wrong.
But 6 out of 85 is a phenomenal rate. I think we should be calling you for recruitment.
We've been lucky.
But so coming to so then you did your army, and you went back to NHS.
Yeah. So
how long you stayed in UK? What happened? What happened after that? How do we find you here?
So I finished my surgical training and got into radiology, and
which was always the plan.
Got into radiology, and during radiology and surgery. Army was going on, 2 months in the army, 10 months in the radiology career. And there was a pivotal shift from neuroradiology to cardiac radiology.
How did that happen? Right? How did that happen?
I think it happens to everybody that there are few people in your life who change the way you do things.
We want to know more on that for sure.
So I had one influential doctor in my senior who was a professor, and
What's his name?
Richard Coulden. Richard Coulden was my guru, as they would say, and I always hated cardiac in my med school.
Don't tell me, man. Don't tell me this. The man who does the maximum cardiac work in the country is saying that. That's breaking news. I got a caption already.
Yeah, you got a caption. I hated cardiac because I always felt it was very, very complex. And I never could get my head around cardiac. The disease process, how you manage them, how you diagnose them was something always an enigma for me, and I was not good at it. Richard Coulden, and there was another chap called James Entwistle. They were my trainers.
In UK.
In UK. James was the thoracic radiologist. Richard Coulden was the cardiac radiologist.
And this was when? This is the year?
This is 2005,
5.
2004, 2005.
20 years back.
Yeah, 20 years back. And they made it so simple. You know, I'm a technical guy. I'm always a tech-minded guy. 1 + 1 is 2. That's how I learn. And they broke the whole cardiac and chest system down to a level where I'm like, oh, I can do this. I understand this. And it was fascinating. It really was fascinating. And that's where every other part of the body and every other specialty, if you look, apart from maybe anesthesia, healthcare is a lot of it is knowledge-based. There is not much technology. Radiology
has. I was about to ask you that was this attraction for radiology more because of the tech part of it?
No. The initial attraction was purely neuroradiology because of patient not getting the services. But then as I came into radiology, I realized I found what I wanted, which is my calling, as they would say. But this is technology, and with cardiac.
But that was more by accident.
It was more by accident.
Or something else.
Yeah, maybe destiny or whichever way you would
No, I mean something else in the sense radiology you wanted because you wanted to detect neuroradiology and interventional, and that started. But then you got into a field which has a lot of tech.
Absolutely.
Which was not really by design, but then it just got into the right place luckily.
Correct. Absolutely. Yeah. And cardiac was even more tech.
Help us understand that.
So if you look at any other part of the body, none of them are constantly moving. So as a radiologist, you are taking pictures. You're basically capturing pictures and you're doing. So if it's your brain, you just make your head not move, you take pictures, you get beautiful pictures. You want to take pictures of your knee, you ask people to not move, and you get beautiful pictures. Lungs, you can still ask people to stop breathing for 5 seconds, 6 seconds, whatever, and you get good pictures. Heart, you can't. Heart has to constantly keep beating. And if you're trying to take a picture of your kid running around, you know how blurry they become. And that is where the technology went leaps and bounds to be able to image the heart, a moving, beating heart. And that is another fascination which triggered. And I realized, well, this is what I want to do. And I had the greatest guys in the world who were training me. And it made sense. Something clicked in the system where everything just made sense.
I used to say when I used to need CT and stuff, so when someone who's new to this would say, when I'm training, say a new sales guy or something like that, can a 16 slice or 8 slice CT do a heart imaging, right? I said, yeah, definitely, it can give great pictures if the patient is dead. Then it's not a problem at all. The best scan is when the patient is.
Remind me about this. There's another thing about me which you don't know, which is relating to patient being dead. I will tell you about that.
Okay, we will go there. So, but yeah, so then this cardiac fascination happened largely due to the influence of your guru, and then of course you found tech a lot in it, and with CT scanners and other technologies probably growing a lot to make that possible. Is that how that
Exactly. And cardiac CT, cardiac MR, you constantly had to work with technology. You constantly kept on innovating. The technology had kept on improving. There were versions of the software every 6 months where I was always thrilled on new versions. Look at that. My colleagues were like, oh God, we have to learn something again. So there was a difference. There was a divide. We could clearly see that technology really excited me. So cardiac was my choosing, and fortunately, I got the opportunity to train in 3 of the best cardiac units in the world. I went to Cambridge, I then went to Brompton, and then
both in UK.
both in UK, and then in a hospital called Glenfield, which is another large cardiac unit in UK. I was a consultant there, and I was practicing. I was doing extremely well. I was in the career doing much better at my stage than other colleagues of mine.
And cardiac imaging played a role.
In cardiac imaging, absolutely. And we were, all these units are the high volume cardiac centers. They do.
So just for our understanding, when you say high volume cardiac, what are the numbers? So give some broad numbers.
In Brompton, we had 3 MRI machines doing only cardiac.
And how many cases would that be?
We would be doing somewhere in the region of 25 to 30 cardiac MRs every day.
Wow.
7 days a week.
Wow.
And that was standard for us.
Right.
In Glenfield, we were doing something in the region of 15 cardiac MRs a day. CTs were less.
And how many cardiac CTs would be there in similar places?
In similar places, we would be doing about 8 to 10 cardiac
CTs a day. Which is also a lot.
Which is also a lot. Yeah. We do much bigger numbers
now. Yeah. So you do what? Now you do about 100 cardiac CTs is what I understand.
So we do about 150 cardiac CTs and MRs a day.
CT plus MR.
CT plus MR. So
CT would be 100 CT.
130 CTs.
CTs and 20 MRs.
Yeah.
Cardiac MRs a day.
A day.
Would you be by far the maximum number of cardiac CTs done in the country and probably top 5 in the world?
Yes, to both. Definitely for the country, nobody else does that many. In the world, the only people who may be doing more than us are going to be 1 or 2 Chinese hospitals.
Yeah, exactly. I just thought that otherwise it's just not, the volume is...
I do know that in US and UK, none of the institutes do these numbers.
So just for radiologists also who's listening into it and others as well, and what is the role of, say, a cardiac CT if you want to explain to a layman in terms of cardiac CT and cardiac MR? What is it for?
So when we look at a cardiac CT, there are 2 broad categories that we can look at. One is screening of people who are suspected or at a high risk of having coronary artery disease.
Yeah.
And then there's another group who are symptomatic, who have symptoms of suspected coronary artery disease or blocks in their blood vessels. And what they have to do is to go and have a catheter angiography, this traditional angiography they may have to go. Instead of that angiography, you're going in for a CT angiography because it is non-invasive and also it is fast, highly accurate, and you're able to get the results from it. In the screening space, which is very, very dear to our heart, is that currently there are no good tests which actually tell you whether you have a coronary artery disease or not.
Right.
So today, if you say, I have a family history of coronary artery disease. Somebody, my relative, passed away. I want to know if I have coronary artery disease or not. You will go and you will traditionally be offered a chest X-ray. You will be asked to undergo an ECG, maybe an echo, an ultrasound of the heart, and finally a treadmill.
And sometimes the nuclear stress TMT or something.
So if you go for the nuclear
Very few people,
stress,
but
okay.
yeah.
If you go for the nuclear, I'll keep that aside. Now, in all of these four, they are useful if you have significant coronary artery disease and there is almost a damage to your heart already. So if you have mild disease, moderate disease, all of these tests will be negative. And you will think I'm fine.
What a CT would give?
CT is the only test on today's date. Even nuclear medicine would not give. Nuclear medicine is another
But
test.
so people who argue, right, in this, and I'm sure you have heard this a lot of times, but for everyone's benefit, is that people argue that the cardiac CT might not be a gold standard, in the sense, might not confirm it, and you anyway will need to do a cath lab. Then why don't I do a cath lab directly? Like, there's an argument some people have.
Absolutely.
And especially if you are of higher age, you would have a certain level of calcification and you'll not be able to differentiate between, I don't know how much of that is real, right, true, but if you can throw a little light on this and the case for it, that would be great.
So if you imagine again 100 people, okay, the issue where CT is not accurate enough and you need a catheter angiography is less than 10.
Oh, really? So in 90 cases,
In 90 cases, you can say, because a lot of them don't have disease.
Of course.
A lot of them don't have disease.
Of
So
course.
we are very, very accurate in them. So they don't have to go for a invasive angiography. Second, there is a group which has mild disease, moderate disease. CT is so accurate that this disease will not be even seen in caths. So you have mild disease, moderate disease, cath will not even see them.
So, but a medicine treatment and a lifestyle change might actually prevent.
Exactly. Which is required for these people. So that's why the invasive angiography really is not.
So would you say as a cardiac CT or cardiac imaging person, would you say that the adoption of cardiac CT is much lesser than what it should be in the country? So considering, and then people of course argue about radiation, whether it should be as a part of the preventive test and screening, those arguments. So a little more light on those factors.
So the medicine is traditionally driven by evidence. We like to have publications, we like to have evidence of doing something to show that it works.
Right.
There is evidence relating to coronary artery disease which comes from the Western world. The disease in the Western world is different to the disease in Indians.
Okay, help us more on this.
We have different risk factors.
Right.
When I was in Cambridge or Brompton, when we are doing a CT reporting list, if you see a 55-year-old having coronary artery disease, we would look at left, right and say, how unfortunate is this guy that he's developed disease at such a young age, 55. Okay.
I'm sure.
In India, I see 25 years old having disease.
Really?
25 years old. That is when it surprises us.
But even at 25, they're getting scanned for cardiac CT?
They come with symptoms.
What are you saying?
They come with symptoms. They have chest pain, they are unwell, they are coming with symptoms. So we are actually finding this.
This is because of lifestyle changes mostly, or?
A lot of it.
Is this a lot? Is this a lot? Like,
so
you do 100 cardiac CTs a day. So you have actually a great database.
So we
how many would be in the age group of, say, not 25 but 25 to 45 and have a reasonably serious cardiac risk?
I would say we are collating our data. We are in the process of publishing our data, and what we find is the group of people who come to us for getting scans are not a general population.
Of course, it's a stratified
very
sample.
stratified
So there will be a higher number than the sample population, no doubt. But still, right?
Surprisingly, under the age of 40, we still find 15 to 20% of our patients having disease.
And this disease level, if detected in this scenario when it is, how many would need intervention, or a lot of them is at such a level that they can be actually treated through medicine and disease?
Okay. So a lot of these are preventive cares. They don't need intervention as in a stent, but they need to be put on statins. They need to be put on lifestyle modifications. What we have traditionally seen, I've seen my friends who come and they say, hey, Vimal, can you scan me? And I say, why do you want to scan? What's happening? General questions. And we look at their blood test and I say, your cholesterol levels are high. You need to be on statins. You need to start medication. They say, no, Vimal, I'm going to go change my diet. I'm going to exercise. I'm going to become much fitter than what you're seeing me. Give me 6 months and I will do that. 99% of them never achieve that. Okay, 6 months later is the same. Same point, I do a scan for them and I show that there is already calcium deposit in your blood vessels.
The adherence is much better.
Adherence is fine.
So you're saying actually, this is a very interesting point, right? This is very interesting point. So you are saying, okay, even if you had not taken a cardiac CT, by your blood test, if they were having higher lipid profiles, and correct me where I'm not a doctor, but still, higher lipid profiles, and had the discipline to take the medicine, probably cardiac CT was not required as much.
Yes, if they are asymptomatic.
If they are asymptomatic. Of course, if there is a symptom, we will come to that topic as well, because that's also very important in terms of understanding the cardiac CT role. But if they are asymptomatic, they have no such big problem, but higher lipid levels, and had the discipline to take the medicine that most don't. Everyone knows, like I'm probably one of them, right? Most don't. We take it for, my dad is a doctor, so I probably take it for a while and then again stop.
Really?
But at the same time, if they had done a CT, just because of that evidence in front of you and because you measured it, the adherence to that by the same person is much higher.
Absolutely.
Right.
And also there is a subset where the lipid profile is normal and they still have disease. Which can be detected in the CT. Which will be, only CT will tell you, no other test will tell you.
Wow. And we want to talk more. I definitely want to talk a little more on this, but I want to cover the symptomatic part as well. In the symptomatic part, what is the role of CT? Because should they have gone directly to cath versus doing a CT?
So in the symptomatic part, you again have two separate groups. One is very acute symptoms where they have ECG changes.
Right.
They go for a catheter angio. There are specific ECG changes, they go for catheter. And then there is a large group of people who say, I'm okay now, but whenever I climb stairs, I'm getting symptoms. I'm okay now, but by 5th kilometers of walking, I'm getting those symptoms. So these stable patients, CT makes a huge difference for them, because a lot of these patients don't have coronary artery disease.
Okay.
A lot of these patients have symptoms, but they are not typical chest pain. They are atypical chest pain. They are related to reflux. Okay, they are related to them not being fit. They are related to other things. Recently, there is a big trial which came out of Scotland.
So you were saying, if I get this right, sorry, I got if you are saying that actually it's the other way around, you are saying the role of CT is to actually filter out those people who don't need to go to a cath, who otherwise might have gone because of symptoms, or because of fear of symptoms that they might be having a chest. But this will give you a more conclusive yes or no, saying that is it because of a heart disease or something else.
If you look at the history of catheter angio, okay, why did CT angio come in?
Yeah.
People were doing catheter angio And they were finding that there are lots of normal studies that they are doing.
Yes.
Patient has typical symptoms, they take them, do an angio, it's all normal. But it's an interventional procedure. You're putting a wire in your heart, there are complications. So they said, we need a gatekeeper. And CT was essentially a gatekeeper. That's how it started.
Actually, a great gatekeeper.
It's a great gatekeeper. And saying 100 people come, 80 of you don't need anything in terms of catheter angiogram. Out of those 20, 10 will need, another 10 we will give some medication and bring you back. So the role of CT has to be seen as a filter who is, segregating people into the right set of groups and preventing people from having unnecessary invasive procedures. There is a lot of criticism. Okay, there is a lot of criticism. People say no symptoms, no scans. I often say this, and this is something which very true for you, me, and everybody. How old is your car? My car is 10 years old. How often do I take my car for a checkup? Every year. How old am I? I'm nearing my late 40s, 50s. How often do I go for a checkup? Almost never.
But would you suggest, for example, and that really makes this a very concrete discussion in terms of, do you suggest that if someone is, say, 40, broadly, or whatever that age is, 40, 45 age and above, cardiac CT angio should be a part of the preventive health checkup?
So when we say cardiac CT, there are two components of it. One is a calcium score, where we don't give any dye, we don't put any needles, we just walk in, walk out. 10 seconds is what it takes. And then there's an angio, where we put a dye and we do that. Asymptomatic people in their 40s, men, even if you have family risk of diabetes, hypertension, men above 30, women above 40, otherwise 40 is a good cutoff. Calcium score is sufficient.
It will give you an idea.
It will give you a very good idea. If your calcium
and those are accurate.
They are very accurate. If your calcium, there is no calcium, your calcium score is 0, we don't need to do anything more.
Okay, so it's conclusive
asymptomatic. It's conclusive enough if you're asymptomatic. And that
that should be a part of their preventive
It should be a part, and it's not an annual thing also.
Yeah.
If your calcium score is 0, no need to worry for the next 3 years.
But once in 3 years after 40, you should do a calcium score and should be a part of your preventive testing.
In India. And for Indians. This is not applicable to the Western world because they have a different...
The incidence is different there.
So that is where... And the radiation dose is very less.
Yes, nowadays.
With calcium score, it's almost, I wouldn't say negligible, but it is very easily...
Which is very different than what it was. And I think I feel sometimes, right, with being in this industry, many a times the physicians who are at the front end of this still have the perception that CT radiation is of the levels that they probably had learned at whatever time that would be. And the progress in the advance of CT in terms of the radiation dose that has come down is not that they are aware of. So for smaller things, so for things which could have been very useful, there is a hesitancy to do a CT, even the benefit is significant.
Yes.
And I generally give the example of kidney stone, where, probably the gold standard, and you can correct me if I'm wrong, the gold standard is like CT. But most physicians would give an ultrasound. And there can be two good reasons. Of course, one good reason is the money spent. But there's also a reason that they give, when I asked few of them, is the radiation dose. And I was like, gosh, now that radiation dose is like an X-ray, would you really not give your time X-ray to find this out?
Correct.
Versus now, because that CT has become... And most of them don't know this, that this has gone down. But anyway, so that is one hindrance. But what would be so this whole thing, right? That's calcium scoring, and then probably doing even angio if it is symptomatic, or if there is a higher score.
Correct. Exactly.
Doing this is done much less than what probably should be currently.
Absolutely.
Much lesser, right? What do you think what are the barriers? What is stopping it? Is it the know-how of the physician on this topic? Is it the risk of radiation, or is it different ideologies about doing this? What is stopping it really?
So we are perhaps doing 3% or 5% of the volume of cardiac calcium scores in the country that we should be doing.
Wow.
Okay, we are probably doing that much, which is very worrying because we all know that we have coronary artery disease. Prevalence is very high, and there are things you can do to alleviate the risk, but people are just not doing it. Why are we not doing it? First and foremost, I think there is a gap in technology availability. For doing a decent calcium score scans, you need a 64 slice CTs for a decent. You can do it in lower ends also, but you need that 64 slice.
So 64 detector. I'm
64, yeah.
Sorry.
64 rows of detectors. Yes. In that. Second is the knowledge and the, what shall I say, the cardiologist acceptance for this is limited because they have not got exposed to this during their training.
They still think it's a competing modality than collaborating.
CT angiography can be construed as a competing modality. Absolutely.
Is it really? Because the general argument to that is the counter argument to that thesis is that if you do more CTs, angios, you'll actually have more cases of people because the capture rate would be more. After saturation, probably then you're right. But till it saturates, which is far away from, you'll actually get more number of cases to be operated upon by an angio, cath lab, angiography and plasty, because you have detected many more.
Which is absolutely
Is that a right way of looking at it, or no, not necessarily?
If you look at our experience at
US is a great experience.
At NarayanaHealth.
Do both.
I go back to this example, you have 100 people who come to a cardiologist, and to all the 100 people you say, you need a catheter angiography, invasive angiography. The conversion rate is around 18 to 20%. And the only 18 to 20% are those who really have bad symptoms.
Yeah.
And
you just can't do anything.
Can't do anything. No, that's 18. The same 100 people, you ask them to have a CT angio. The conversion rate is 90 to 95%.
Right.
Because for them, it's another scan. It's an outpatient scan straight. And when you're scanning 90 to 95%, you are actually bound to found 25 to 30% disease, because that's the prevalence of prevalence. So eventually your numbers increase, and you are doing the interventional work which needs to be done, not the normal diagnostic.
Exactly. You're actually using the invasive procedure for intervention therapy rather than just for diagnostic.
Absolutely.
Which is far better way of doing it.
Exactly.
And you're using that asset in a much more profitable way, also from a very business angle as well, like from the number angle, which is also important. I mean, having the economics behind it working as well is very important. But that's what would happen. Absolutely. But anyway, going back to the challenges or why this adoption. So one is, you're saying
technology, we don't have enough of scanners that is available. Second is the understanding of the disease process and what does the calcium score give amongst the clinical community is limited. Third, which I find, is these things will be driven by patients. These things are driven by patients. So we've started having patients come and say, I want to.
So patient awareness.
Patient awareness is not there.
But if the doctor, who is the physician, says that it's not required because they really don't think it's required, then it becomes very difficult, right? Is it? People do direct choices as well.
People do direct choices as well. See, one of the biggest problem which I say is we follow Western guidelines. In Western countries, for example, UK, healthcare is funded by the government. Okay. And for a government to make a test available as a screening test, for them, health economies have to make sense.
Right.
They have to have a pickup rate of 10% before they make it as a screening test. And in their population, it doesn't work. So they say we should not be doing this core test at all for screening. We cannot interpolate that data to us.
This is very interesting. Yeah.
Okay. And if you say, okay, 8% is the prevalence of disease. So you should not have this test because the disease is only 8%. But to you have a 50% chance of having the disease, not 8% versus 92%. Do you understand? For me, who is a health minister, I may turn around and say 8%, I don't want to roll this package out for people. But for an individual, so in India, when individuals can pay and then they do that, it is much more worthwhile for them.
And you are anyway saying Indians need it more.
Absolutely.
Than actually the UK and US and the Western developed world, which is a little different thing because generally they do much more testing.
Correct.
But you are saying we need more testing because of our
Genetics
and predisposition to this coronary artery disease.
See, the one thing when we started doing this, if you look at it, we started doing this 6 years ago. Our calcium score cost was less than a Starbucks coffee.
Wow.
Okay. It was.
So its cost is not exactly the prohibition.
Cost is not a problem. Even on today's date, it is cheaper than a meal. You can come into our hospital, get a calcium score, and it is cheaper than you going out on a meal. And it gives you so much of information.
So I want to summarize this barriers, cardiac CT adoption barriers, and quickly for people as well, and just for me as well to understand, and then move to really the MR cardiac imaging as well. There's so much more actually to talk, radiology, NIA and stuff like that, which is there. But the cardiac CT, right? The cardiac CT, one you're saying is the availability of the machines for cardiac CT in India is not there because of probably price or technology. Second, you mentioned is that there is still that awareness amongst physician as well as even cardiologists giving this as an adoption in terms of CT for their is we're still struggling with it. We are not there yet.
Correct.
What else? What else are the barriers?
I think these two are such a major barrier. For example, people, I go and train a lot of people and I say, calcium score is the easiest thing for you to do.
But you train whom?
So I'm training radiologists. I go and speak to conferences where I speak to the cardiologists.
Superb. So you train radiologists. Physicians are still outside the circle.
Yes.
Right?
Yeah.
They still don't know, but they have a role in here.
Yes, absolutely.
Right? They have a role.
Yeah.
Still, I think a lot of people, and correct me if I'm wrong, like a lot of people go through the physician route from a healthcare delivery system.
Yes.
They still don't come directly to a cardiologist for a chest pain. Lot of them might be, but still I think significant would be going through their general doctor or a physician or through that. So they are yet not done. But even radiologists, what is interests me, and I know of course your work on training, and that's another big chapter we need to discuss. But you're quite committed to train. And you do cardiac CT courses and cardiac MR courses, so entire imaging courses for radiologists. And that's where we once had interacted a lot as well. Now, why is that? Why doesn't the radiologist still, that means has the radiologist is not yet adopted cardiac CT as much? Or is it they need to learn something more about it? Is it a skill thing that they get? What happens in this training really?
So if you're talking about cardiac CT, angiography and cardiac MR, there is a learning curve for people to start reporting.
And is that a barrier as well for adoption? Because the radiologists themselves are not pushing it to their physicians that let's do a calcium scoring or stuff like that. Even if technology is available, because they don't have the confidence to do the cardiac CT yet because they've not done it, the skill set. Is that also an issue?
So calcium score, no.
Okay.
In the terms that the skills required to report a calcium score are not that
much,
high.
yeah.
It's very straightforward. CT, Angio, and cardiac MR, the skills required are high, and there is a shortage of well-trained people, and that is one of the barriers for adoption, and that's why we train. I'm so passionate about it that I want people to take it up, and the reason there is shortage is because the traditional training programs that we have, majority of the institutes don't do cardiac imaging. So it's a catch-22. We don't.
So while they're learning, they're not learning this.
While they're
they have to upskill them at some other point of time.
Correct. They have to go somewhere else, learn, and when they start doing, then they will start training next person. The next
And that's
person
what you're trying to do in your own way while doing this cardiac. And you do it on online as well, right?
We do both online and on-site training, and we've had great adoptability of both.
Tell us a little more on what the batch size is. How do you deliver that?
So
If someone wants to like really look at this, what they should be expecting?
So if people are interested in joining any courses of ours, they need to go on LinkedIn and follow me on LinkedIn. I'm reasonably active on LinkedIn, and I post my courses there. When we are doing an online training program, I do not believe in didactic lectures. I really don't believe. So my training programs are always hands-on workshops. We give them cases, people have to work on them, produce reports that I can then look, critique, and tell them how they need to do. Usually have a course size of about 25 people.
How often you do this?
And we do the online twice a year.
Okay.
And one will be cardiac CT, one will be cardiac MRI. It lasts for about 6 weeks, is one course. On site, it's over weekends. We are now starting a mini cardiac MR fellowship, whereby we are going to do it run over 6 months, where we're going to train people or handhold people from basics to a level where they can go and report. So this is something which we do in collaboration with NH Narayana and another group of trainers. We do that. And we are seeing good traction.
So in a year, you're about training about 50 people on cardiac imaging or
No,
more?
I end up training. So the on-site programs have a more number of.
Oh, this is only online, you're saying?
This is only online.
So total, how many people you train in a year?
If we train the full complete as a full course, we are looking at least 150.
150.
If we are looking at just a one-day program and stuff, then it reaches around 400 odd people.
Already.
Yeah.
Yeah, but then there is much more scope, right? 150 is
Absolutely.
but not bad number to like cover. But then as this goes, there are many. We have like 15,000 radiologists,
Correct.
and a big chunk of them might benefit in general from upskilling to cardiac work.
Absolutely.
Right? In general, I mean, not all of them, of course, but as technology also penetrates more, so just from a tech side, right? So post-COVID, right, when CT business, from a CT business perspective, the penetration of 1632 slice really happened extremely well over the last 5-10 years, since more affordable technology has been made in India. But in COVID, of course, it penetrated a lot more. Post that, we see a trend of actually 64 row detectors going in places where earlier they didn't.
Yeah.
So some of it is happening now. The technology availability is happening there. And I think it's like both this working together might actually make it happen much more, I think. Absolutely. I mean, that's
Absolutely.
And that is one of the barriers for adoption of cardiac might go, apart from of course the awareness of patient and stuff. So great. So let's move from CT then to MR. What's the role of cardiac MR?
So
It's even less penetrated in you.
Yes, absolutely. It is. There is a huge scope for cardiac MR also. And what is interesting with cardiac MR is it is not a competing at all. It's on its own. What it does, nobody else can do. It is not a replacement for anything. It just provides information on top of everything else.
So what does it give?
So,
Say, for example,
in a scenario where people go and say they have got a heart problem, the heart problems are broadly classified because of blockages, coronary artery disease, and everything else. Coronary artery disease is CT and catheter angiography, etc. Everything else is where the heart is not working because of a problem in the muscle of the heart. And what is the cause for that problem is being answered by MRI.
okay, and no one else gives this.
No one else can give this.
So what happens if they've not done a cardiac MRI to those patients? What do they do there?
We treat them empirically. Echo gives a little bit of an idea, and echo says that it is likely to be X, Y, or Z. But cardiac MR gives that confirmation that no, this is A, B, or C. And these are factors which mean that the patient will do poorly in the next 6 months. You need to intervene in them. So echo is a gatekeeper in this scenario, the other way around. Echo does a fantastic job, needs to be done in all the patients that we are talking about. MR is restricted for people where echo says, yes, there is a problem, and MR is going to come and tell what is the problem and how we manage it.
And then the adoption of cardiac MR must be even lesser in
Yes.
terms of, and of course, probably the need is also much lesser than a cardiac CT, am I right? Because the number of such cases would be less from an absolute number perspective, I mean.
Absolute volume, you would imagine, yes.
Yes. But the penetration to what is needed is even also lesser.
Absolutely. Absolutely. And what is the major reason, again, used to be technology in terms of MRI machines, whereby you had MRI machines, but they were not capable of doing cardiac scans. That is now being tackled. Most of the MRI machines do MRI scans.
So this is something that technology enabled to,
Yes.
right? This is a more recent, relatively recent technology developments that has enabled
Correct.
to get that information from an MR, which probably earlier was not possible. Like 20 years back.
Correct. The cardiac MR first cardiac MRs were done in early 2000s.
Yeah.
So it's not been that long it's been around 20, 25 years in technology. The big barrier in cardiac MR is not hardware right now, is the software. To process a cardiac MR,
So it's still a technology problem.
it's still a technology problem, and it's a problem in India. Because
Okay.
the software will cost you on today's date anywhere from 40 lakhs to 80 lakhs.
So you're saying it's not the availability of technology, but the cost of that technology.
Cost of the technology. So, which is something we are solving. We have some solutions which we have built, which is where my tech and AI also come into. The third thing, which is the lack of trained radiologists,
Yeah.
which is a big barrier. So, even if you have institutes which have the MRI scanner, they can get a decent software for reporting. We don't have enough radiologists.
So for someone who is entrepreneur, who's watching this and is in healthcare and then entrepreneur, is it safe to say that there might be a great business opportunity in building a training business in terms of training radiologists or upskilling radiologists? Is that big enough a business for someone
is a
to
good
really do
business.
full time?
It is a good business. Is it a big enough business or not is a difficult question to answer, because this need a lot of people are trying to solve. So, for example, we are trying to solve, NarayanaHealth is trying to solve, Indian Association of Cardiac Imaging is trying to solve. There are multiple players who are trying to solve it.
You're saying it's fragmented.
It is fragmented. It's heavily fragmented.
There's no moat for one to kind of get together.
Correct in that to do that. So there is scope for a business, but I don't think the market size is big enough for a business to really solely do this.
But current best ways is like enhancing the training capabilities and doing
Absolutely.
something like that.
In that.
Yeah. Super. So going back to the to your lifeline in terms of so you're in UK, then you came to India. When did you come to UK?
So
And what
I
made you
came
come
to
to
India in 2011, 2012, and accidental. And I had just been to Afghanistan. I came back. I had an extended holiday, and I was in India for my co-sister's wedding. And I had not properly worked in India. I had done my med school and I
Exactly.
had left.
Yeah.
And I was always fascinated of how does Indian institutes work? We should be knowing about it and seeing, is there a career opportunity for me here? And to cut the long story short, I met Dr. Devi Shetty, and he
inspired you to get in,
yes, absolutely,
which he has done for many, I think.
absolutely, and he was the other influential person in my life who has made a great contribution in shaping to
What did he say to you?
he basically he also comes with a similar background. He also trained for a long time in UK.
Oh, really?
He did spend his surgical training in UK, and then he came back and he said, Vimal, we need people like you in India. We need people to set up India, because he believes in disrupting the market. And he believes that in cardiac imaging, there is nobody there, because in India at that time, even now, radiologists want to do head to toe. They want to do everything. And I was so niche area of expertise. I said, I'm going to do cardiac. And he said, we need people like this. Come set up our unit and help us in growing, help us in treating our patients better. And I said, great.
You got sold on that, and obviously, you've been there since then.
I've been there since then. It's been more than a decade now.
Yeah, 14 years, 15 years.
now.
Yeah.
I took a pay cut of, I was being paid 10% of what I was earning in UK.
How did you make that decision? I think there are many people who are at that kind of decision making. Sometimes they have to make those kind of decisions in life. So what made you do this really?
As I said very early in our talk, I told you that somewhere in my nature, I feel I had to give back to the community, to the world of what I've done, the righteousness of that. And I felt this was my calling to give back.
But still, it's a solid, I mean, it's a decision which is not that easy.
It is,
I mean, see, the way I see it is, of course, if you didn't have that calling, you would never even consider. The way I see it.
Correct.
That even wouldn't have attracted you if that was not in there.
Correct.
It's like the CT detector and the detect at least hona chahiye, na?
Absolutely.
But to take it, right? That decision where you really make this, you have to have certain benefits that you foresee over a period of time, which might not be necessarily monetary, but there has to some equation that went in your mind, or you were completely like, nee, we will do this and let's see what happens.
Even if you ask my wife why we came back, and she said, one morning you just woke up and said, shall we go to India? And she was also shocked. And
what was her reaction? Like, she was okay to...
we were a big group of people who had gone from India to UK. We had a very close friend circle. And I was doing extremely well in UK. And I would have been the last person to leave UK. Because I was doing so well.
It was very niche. And
I am a sports person. I was playing the Leicestershire League of Volleyball.
So you were not only having a professional great time, you were also having an overall great time in terms of your lifestyle. Some people don't enjoy, like say, staying in London because of whatever, or UK for other reasons, right? In the sense they're doing well professionally, but they find personal calling in terms of people or the lifestyles, they don't like it. But you were doing all of that well.
I was doing extremely well.
So how come? I mean,
and then I look
apart
back
from
at
thanking Dr. Devi Shetty, what is it that made you?
No, I think maybe the other thing which was a driving force was we've seen a lot of our seniors who were in UK, who were near their retirement age, they always used to say, we should have gone back to India. We should have gone back to India.
Oh, yeah.
And there was always at the back of my mind that I need to go back to India.
Sometime this came in, why not now?
Why not now? And if it doesn't work, we can always come back. We came at the same time. There were 15 of us in my close circle who had come. There are only 2 of us left in India. 13 of us went back.
Oh, really?
Just the 2 of
But
us.
15 came?
15 came. This is my circle. There were lots of people who came around at that time.
Oh,
But 15 people that I knew came. 13 of them went back. They just could not survive.
Just let's spend a couple of minutes on this because we have some exciting stuff else to cover. AI as well, I want to talk for sure. But this whole thing, right, for UK healthcare and Indian healthcare, if I have to put you on a spot and say, okay, what about the healthcare system, like professional satisfaction that these people probably didn't have, which made them go back? What is it? Like, what happens between these two? What are the pros and cons of this healthcare system in general for people as well, and as a healthcare professional as well?
So for a person, as a patient, if you have money or insurance in India,
Is better,
you
is it?
will not get any better healthcare.
I always say that if you are amongst the well-to-do people and access, there's nothing like Indian healthcare,
Absolutely.
isn't it?
If you are non-affordable or if you do not have insurance, then, and with a caveat that you have serious illness, UK health system is great. You need to have a serious illness.
Yeah.
If you have a back pain,
You are not. The time taken to look at you is just
6 months for a scan
back is gone.
and everything is just not. So if you have a cancer or if you've got a heart attack or something like that, it's a great system. But in India, if you can afford or if you have insurance, if you can't even afford, get an insurance and it's great. From a medical personnel point of view, the Indian system is competitive. You really have to work very hard to survive in the system and to excel in this system. There was a time when the gratitude of patients was an extra incentive, which
you don't see now.
going. And that has come down significantly.
yeah. You see that?
It's become more transactional. This is what happens in the Western world.
You mean like a consumerist?
It's a consumerist. People are, I'm paying you, you're here to treat me.
Yeah.
Why should I thank you for whatever? That's what is the trend which is happening. So when people came to India,
Why is it more competitive here?
because it is most of it is private driven. There it is a government and beautiful system. I really love that system. Whether you are a neurosurgeon, dermatologist, pharmacologist, you get paid the same salary.
Really?
You get paid the same salary.
But you are saying that's nice, but the neurologist might not feel good about
But
that.
that's how the system is run all along. Even before
Why
you,
I knew this? So you are saying all specialties, a cardiologist gets paid the same as a dermatologist would.
it only depends on how many hours you work. So if I work, let's say,
You have that option to have different hours. To
so minimum you put 40 hours a week.
okay.
Some people, because
can
of that,
do
they
extra.
do a little bit extra. And that.
So it's hourly.
It's not hourly, it's called as a session.
No, but what I mean is it's the only variable in earning is
How many hours you
how
put
many hours.
in there. So there is no, so
Wow.
then
So if you do a surgery versus a diagnosis, you get
Same.
paid same?
exactly the same.
Oh, this is an insight for me. This I didn't knew at all.
Yeah. So
Yeah.
there's no competitiveness in there. Do you understand? Because of
Oh
that.
yeah, of course. I mean, but does that also mean? Does that mean loss of incentive to do few things?
Yes.
Or that's just a perception. Like
It does.
Yes, it
There
does.
is some time when, the neurosurgeons or a surgeon who is doing 6 hours of work and then comes and sees somebody else is not doing. But what that system recognizes is it's not just about skill. It's the amount of time and effort that you're putting into that.
so, people there. Now I'm tracing back to education because this is very interesting. people there who choose neuro or cardiac do more out of interest, not because they have a better career graph, because they could have done any medicine and could have earned the same.
Correct.
Which is very different from what happens here.
Absolutely. So that,
But in a way, isn't that good? Like they really come out of their interest, not really from
I
the
love that.
incentive to monetary gains or otherwise, or status gain or something like that.
See, I love that system, and that is what basically makes me.
Does that also mean they have similar status? In a sense,
They do, and
like a neurologist or a cardiologist wouldn't be treated like with more the way in India. I mean, I always say the difference between God and cardiologist is that God doesn't think he's a cardiologist.
in the hierarchical system in the NHS, human kindness and humanity is more important, which basically means the janitor can tell of a cardiologist, cardiac surgeon in NHS, you're walking when I've just cleaned, walk on this side. And he will say, I'm really sorry, and you walk. Okay.
Yeah.
Which is in a manner where,
Which is one thing in terms of, I think, the basic human respect. But also this whole incentive to do is only based out of interest. Rather than, which is very interesting. So in terms of numbers of what they do, and of course we want to go to another topic, but in terms of the numbers that they do, or the number of specialists they are, does that mean they have a much more number of, so it's not like super specialties are much lesser than
not necessarily
the other doctors, or
so for example, let's say,
because they're doing out of interest, not really the ranking system in terms of getting through is very tough.
so getting through is tough. It is all not purely based on your clinical acumen, but your overall personality of how well you do the job, how well you publish, what research work you do. And there is a clear-cut pathway for super specialization in there. So it is a lovely system, but because it is government funded, it is overwhelmed as of now. Patients struggle to get appointments. Doctors are overburdened. Junior doctors are really struggling.
But would they, controversial question, right? Would they actually do more without feeling burdened if they had incentive to?
They already have incentive schemes, and they are
Like if it was a private system here the radiologist doesn't complain, but he has more burden than many other countries. But the radiologist does that job.
So there is a parallel system there, which is a private system, and they go and do in private where they get paid very well. And then there is a difference in there where the neurosurgeon will get paid more and than anyone else. But that private system is
Very small.
10%,
Yeah. And UK is centered. Yeah.
in that.
So super. No, great. So now let's move to a topic which is of immense interest to many people, as well as is very exciting, and also connects to the future of radiology in a way. Radiology and AI. What do you see? How do you see AI playing a role in radiology? It's the most penetrated ology in terms of AI. 75% of the AI applications in healthcare, having FDA are radiology. So how do you see this shaping radiology? And then any examples which can kind of help us and whoever listening understand what's happening in this field?
So radiology is at the forefront of AI, as you said, and that is going to be the case for the next 2 decades.
Is it because people like you who are generally tech savvy who come to radiology, or is there no?
It is primarily
Pattern
because we are dealing with images.
Data.
The data is a digital data that we are dealing with majority of other specialties don't have.
The availability of good quality raw data in radiology, probably because of the historic adoption of
Correct.
tech in a way, and packs and images and pattern being
It's that is the reason, and it will shape the way we all do practice radiology. It has already transformed the way we do a lot of things. For example, I'll tell you, if you look at the way UK system has gone, UK system started with radiologists reporting everything. Then the number of radiologists was less. There were more scans to do. So we started training nurse practitioners or radiographers to do ultrasound scans. 80% of the ultrasounds in UK are not done by radiologists.
I
Done by
understand the
sonographers.
reporting is also allowed in some of X-ray at least.
Exactly.
Isn't it?
So that was first ultrasound.
Do you think we should
Next.
follow that?
So next came X-rays,
Yeah.
where because they were short-staffed, there were so many CTs and MRs to be done, they got radiographers to do X-ray reporting. Now, if this happened now, AI would do that.
Yeah. AI plus a radiographer can do even more.
Or a radiologist.
Yeah.
Rather than training another group of workforce.
Oh, you think it can be completely replaced actually?
It can be completely replaced. For example,
So
India
we don't need to go through the radiography training route. We can just directly go to
we will jump
radiology
that
plus AI.
cross. We will jump that because now AI is available.
And the use case for this is normal, abnormal, or is that more to it?
Even everything. See, the one of the biggest problem when people talk about AI adoption is they say, how accurate is your AI? Okay, and people say our accuracy is 95%. They say, oh, you make 5 mistakes in every 100 cases. And people feel, yeah, and they say, oh, that's very bad. But nobody knows a radiologist accuracy.
Exactly.
Nobody has tested a radiologist accuracy.
And the other field we'll come to, which you're kind of working on that as well. Very interesting. Yeah.
So this becomes a major problem. So on a good day, I would imagine I will be 95 to 97% accurate. I would like to think so. On a bad day, I have no clue what my accuracy is. So AI is going to become a big time assistant to me.
Where do you see the applications more? Like, where will it help you the most? The AI in general, or where will it take over in terms of certain work? So is it more in terms of productivity, in terms of allowing the radiologist to do many more things because of removing certain kind of work, like normal, abnormal detection or few others, or is it diagnosing better or workflow optimization? Which are the areas you are seeing AI applications coming in and also are useful?
So I think all of these, to be honest, okay, when you start off whereby workflow optimization, whereby prioritizing my work list so that I am dealing with the emergencies more or abnormal ones than normal ones, that is something AI is doing a fantastic job in. Second is where we are able to segregate normal from abnormal. AI is doing a good job in there. Third is complex repetitive tasks that we have to do. I'll give you an example which is very pet to me is cardiac MRI. I remember when I was training in cardiac MRI, it used to take me 45 minutes to an hour to report a cardiac MRI because we had to draw contours around each slices of the heart, which would take me half an hour to do that. Today, we have developed an AI program which does it in 30 seconds.
Wow. Seriously?
Yes.
Wow.
So we do not have to do that. I manually do not have to do that. Now this MRI scan, which would take me 45 minutes to an hour, I report it in 10 to 12 minutes because AI has processed the data. AI has prepared the data for me to go and say, okay, this is correct. And I put in my expert opinion at the end and the report is ready.
Yeah. But there was this kind of fear, and I think still is there among some people, have reduced probably over the last 2 years as AI is evolving so rapidly. But that will AI really replace radiologists most of the tasks, or any for that matter, not just radiology, but many more. Today we are talking at a human level whether AI will make humans redundant. But from a radiology perspective, where do you see, what would be your response to this argument in terms of AI taking disproportionate share of radiology's work and still the accountability lying with radiologists being completely this tussle and conflict between who is accountable versus what will actually take, and also the counter view to that in terms of no, it can actually enable and one should use it to his benefit. Where is it going? Little more like if you distill it in terms of how you see this is happening.
See, when people said AI will replace radiologists, there was a big uproar about it. And then people tried to sugarcoat it by saying AI will replace a radiologist who doesn't use AI, but
A radiologist using AI will replace a radiologist not using it. Yeah.
Honestly, the bottom line of that is AI will replace radiologists in terms of if I am recruiting 5 radiologists in my hospital to do CT reporting, X-ray reporting, I will need, with a good adoption of AI, only need to recruit 2 radiologists.
Okay. So that it will replace
It will replace.
But in that sense, with so much gap between between the number of radiologists required, so called, for the population, would this mean it's not actually replaced, but they will you will see more radiologists actually in places where today they are not?
See,
or how will that?
that is the aspirational thinking. That is what ideally should happen. And this is
But might not.
It does not happen. See, if you look at,
So would you say, for example, and I'm opening a box, I know, but would you say someone who is right now has done their MBBS and is choosing an MD program should think carefully before choosing a radiology versus others?
no, I think it's not that. I think radiology still is one of the most rewarding specialities. If you are of a mind where you enjoy diagnostics, not being a front face in front of patients, treating the patients.
Yeah.
Okay. Of course, interventional radiology.
The
does, but
career of radiology will remain. You are saying much more.
Absolutely.
And there is no reason why they shouldn't pick radiology if it's their interest. Just because career prospects wouldn't remain.
Correct.
But why would it? If those are getting replaced, why would it still have that demand?
See, the thing what happens is on today's date, the big question, which again you have also asked, is who is responsible for this AI? Where does the
Accountability will still lie with-
accountability is going to be with radiologists. And AI is not yet there in a lot of things. It is there in some things. It is very good in some things. I had a discussion with one of my senior colleagues and they said, no, it's of no use. I said, AI on today's date is much better in a chest X-ray scenario, is much better than my 90% of my residents. AI is far, far, far better than 90% of my residents. So I'm getting
Do you see it adopting this? So do you see many, and we'll not go to a particular institute per se, but do you see many institutes adopting AI in India? Because general perception I have and notion, and I've been in AI for a while, is that the adoption in India is very low. People still don't. Is that changing dramatically, or
depends on the solution. Overall, the adoption is very poor. But then there are some specific niche area solutions that people are really adopting it. For example, the solution which I was talking about, many CBI,
the
cardiac MRI, it's being adopted by individuals so rapidly because it is making their reporting very, very easy and fast.
So in a way you are saying, and probably this is more input to the lot of the multiple startups in AI. If they have to do something, it's encouraging, but they have to really find a meaningful solution to it.
Meaningful solution which is cost effective.
Right.
In India, the price consciousness is too high. And the ROI is difficult to prove in an AI solutions as of now. And that's where the adoptability is low.
Is it ROI generally the bigger one, or the clinical still not validated, or what is bigger?
So even for a validated product, the ROI becomes the barrier.
Right, of course.
So if you don't have a clinical validation, you just don't even come on the table for discussion. So you need that clinical validation. And then if it is not getting adopted, that is purely because the ROI is.
But you must be meeting a lot of AI companies, right? A lot of AI. Are they? If there are two things before we move to the final session, but if there are 2 to 3 things that these AI companies should really learn, right? In terms of, are they, first of all, are they really solving the problem that you guys have? What would be broadly, not one or two, but are 80-90% of them that you see are really solving a problem that you have?
60% are solving the problem that we have. So there are still 40% who are not solving our problem, but they're solving somebody else's problem.
But are they?
They are.
Are they? Because one of my notions is many a times they've not understood the problem. I strongly think many a times they're technology forward, in the sense that they have a tech, they know they can do this clinically, they do it without trying to find out whether that problem is as big as a problem that they need to get solved by this technology as the best way, or so in that sense, are they really useful enough to get paid? All of them that come, like a big percentage of them, or are still a lot of improvement in that area?
So it's very tricky to answer that, because, for example, when somebody comes to us and says, we've got a solution which can pick up nodules in a chest CT, we don't want it. But the same thing when we were in NHS, we would love to have it. Because we do so many nodule follow-ups, which is a headache. In India, it's not a problem.
No. So they probably have not understood that market properly.
Exactly. It's a market-specific issue, which is that.
Which is a great point. Yeah, which is a great point.
In that.
Yeah.
So there are people who are solving it. The message to them, I would like to say is, Indian market is very, very, very different to the market that you see in Western world. We've had people who've come and say, we're doing this for X dollars. In India, we'll do for X by $3 or X by $4, 1/4 of cost. And we say, it doesn't make sense.
Yeah.
It seriously doesn't make sense. So I'll give one example. There's one solution, a US-based patented FDA-approved solution, which looks at blockages in the hearts on a CT scan, and it gives very good output. Okay. It charges somewhere in the region of $1,700 per patient.
Oh God.
Okay. And it's fantastic. They get a CPT code and they can claim insurance. UK also has adopted it at a slightly better price. They came to India and said, we want to do it. I said, that price won't matter. And then they said, we'll do it in $600. We do bypass surgeries.
Yeah, that's right. It's just not possible.
It's just not possible.
Yeah.
So if for them it is 1/3, 1/4.
So you are saying in a way, what is true for bigger products, like some cutting edge med tech products, which cannot be adopted in India just because of the cost of those. Even AI, which is a software algorithm, has a similar challenge that a make in India AI might actually help to solve it. It's just that prohibitive because it's made in dollars, it's not being sold.
Correct.
Wow, that's interesting. Okay, that's interesting. Yeah. So going to probably the last part of the discussion in future of radiology, right? Where do you see the future of radiology? Like if you have to see 3, 5 years, 10 years down, how is the future of radiology you see at a broad level and also at a specific?
See, I think there is still a lot of growth pending in radiology when it comes to scans, patient volumes, equipment. There is still a lot of growth. There's still a huge gap between the demand and supply in India at least, and in the Western world also. There will be a significant growth in the machines that are sold, the number of scans that we do. More and more there will be AI adoption. We will be adopting AI left, right, and center, and we will become more and more efficient. Now, if you look at the Indian system, we already are super efficient in what we do.
But you see AI penetration.
AI penetration.
Any other technology you feel, or any other change in the delivery model will change? Will teleradiology, for example, have a whatever, right? I mean, apart from AI, which I get it. Anything else you feel that's going to be a very big driver of radiology?
I think the biggest driver I would like the biggest driver is going to be screening programs that are going to start coming in the Indian market.
So a lot of more testing will happen.
A lot of more testing will happen. Technology-wise, I see many of the OEMs starting Make in India projects. So the cost of that is going to come down. And more radiologists are, I think teleradiology is going to be there. I don't think it's going to become too big or it's going to become too small. I think it's just going to continue the way it is. But I believe there will be, for another 5 years at least, there will be a lot of external Western world country teleradiology coming to India.
Oh, okay.
For the next few years.
Okay.
And after that, the AI will start solving their problem. And then it'll...
Oh, you mean teleradiology done by us for them?
Yes.
Oh, okay, I got it now. Yeah.
In there.
Great. So last piece, I'll do some rapid fire.
Okay.
Right? and then we probably will see what else remains. As a city, Bangalore or London?
As a city, London.
Yeah, of course. Favorite food?
Favorite food, chicken.
Okay. Favorite restaurant in Bangalore?
There is a Chinese place in Lemon Tree Hotel called Republic of Noodles.
Okay. And favorite restaurant, say, in Pune? You come to Pune often?
Pune, not that often, although I was born there. No, I was there in Prost the other day, and Prost as a pub was.
So you should come to Pune. We should go visit.
Absolutely.
X-ray, CT, MR, ultrasound. Your favorite modality?
MR.
MR? Okay. Two things that very few people know about you.
People don't know that I've played national level cricket and county level cricket.
In UK?
In UK, county level cricket and national level cricket in India in my school days.
Wow. I knew about your football. I didn't know about cricket. I used to play cricket.
Yeah. Okay.
For district. Wow. Nice.
That's one. And people don't know that I have a patent in post-mortem cardiac CTs.
We were to talk about that. Tell me more about it. What is post-mortem?
So there is increasing requirement for a lot of geographies in the world when people have an unexpected death. The laws of those countries require them to have a post-mortem where you open the scan, open the chest, body, do everything. Instead of that, you can do a CT scan.
Wow.
And you can diagnose what they died from. So if somebody died from brain hemorrhage,
does that happen in India?
Very, very, very niche areas. It's just started. It's just started, but at very research level. So we were doing this as a big time in UK. It happens in Switzerland. It started in Dubai, Middle East, where as a Muslim, doing a post-mortem is against that religion.
Oh.
So we were doing cardiac MRs, cardiac CTs, whole body CTs, whole bodies MRs for these people.
Very useful thing, isn't it?
Absolutely.
It should be probably adopted at all places. Yeah. Wow. Two most important decisions of your life?
Definitely coming back to India was a good decision. I really, really am proud of that and very happy that I made that decision. Another one was pivoting from neuroradiology to cardiac. In the professional sense, marrying my wife was a very good decision in the personal front. And I think those were the two, maybe even the army. But army, that decision was taken away from me. It was in my hands.
Super. Thank you so much.
Thank you very much. Thank you very much to have me.
Thanks.